Hello, I am Dr. Gus Lividitis, a prosthodontist practicing in Baltimore, Maryland, and co-developer of the Maryland Bridge technique along with Dr. Van Thompson at the University of Maryland School of Dentistry. This is the second segment of a series on etched metal procedures. It focuses on abutment retainer design and tooth modification for anterior and posterior bridges when applied to intact teeth. Additional segments will describe the management of compromised abutment teeth. Take a moment to review appropriate disclaimers. Before we begin, I would like to be certain that everyone is familiar with two terms used throughout this presentation. The term retainer is used to describe the component that restores the abutment tooth and or supports a pontic segment. The term pontic or pontic segment describes the replacement tooth or teeth. Maryland anterior and posterior retainers are usually described in three distinct segments. Proximal, usually referring to the side supporting a pontic or pontics. Palatal or lingual also includes the proximal extension when in contact with an adjacent tooth. Occlusal rest or segment may refer to a small or limited rest or may restore caries or replace an occlusal restoration. We will begin with anterior bridges, retainer design, and followed by tooth modification. When the Maryland Bridge was introduced to dentistry, two general approaches evolved. Option A incorporates resistance features of traditional partial crowns and inlays. This was a reasonable and safe approach. If conventional partial crowns were reliable, why not include a bond feature? Proximal grooves and rest seats or ledges were incorporated. Resistance features were intended to dissipate forces relying less on the metal to enamel bond, and such modifications were typically limited to the enamel layer. The path of insertion or withdrawal is slightly more difficult than option B. In option B, minimal modifications of abutment teeth with no proximal grooves or ledges. Minimal modifications could categorize Maryland procedures as reversible treatment. The vertical stop is temporary and requires no tooth reduction. Modifications for a path of insertion are minimal. Most importantly, option B best evaluates the capability for etched metal retainers to withstand masticatory and parafunctional forces, relying mainly on the bond. This long-term investigation and presentation is based entirely on option B, where the main objectives were to maximize lingual coverage of the anterior teeth, extend retainers to the incisal edge while preventing gray discoloration by other means, expand the application of the Maryland Bridge technique, and also to include individuals with parafunctional habits except when loss of enamel has already occurred. Considerations for anterior abutment selection, especially during the early phase, included intact teeth or limited to intact teeth. Abutment teeth should be normal in size. Very small teeth should be avoided. Crowded teeth compromise the multi-surface extension of the retainer. Worn teeth present less enamel surface for bonding. Teeth with small restorations or carious lesions may be used, especially when internal enamel walls may compensate for lost enamel surface. Altered passive eruption, the high gingival level covering the teeth, often confronted in late adolescence, should be corrected to normal adult level. The proximal segment supporting pontics should be adequate in size to allow a solid connection to support the pontic segment. The proximal area is further contoured with composite resin beyond the framework to eliminate any crevices, for optimal embrasure form, and sometimes to conceal the proximal metal framework. The proximal resin survives decades and rarely needs to be resurfaced. The lingual segment should extend to the incisal edge with an apical slope to avoid display of metal. and should extend to the cervical zone of the tooth using the natural curvature of the tooth as a finish line for the framework. Optimal thickness of the framework is 1 millimeter. It may be 0.5 millimeter or even less in tight occlusal areas. 1 millimeter thickness should be maintained over the proximal lingual line angle supporting the pontic segment. This is to prevent fracture of the framework. The non-supporting proximal surface, usually considered part of the lingual segment, should extend close to the contact without trimming through the contact. Framework margins require no tooth preparation. Even thin metal segments add bond strength to the retainer, and the framework margins can be razor thin. This segment may serve as connection for splints and double abutments. Incisal rest is temporary and requires no tooth modification. It enables accurate seating of the bridge during try-in and bonding. The rest should extend slightly onto the labial surface to position the framework close to the tooth and also serve as a vertical stop during insertion. In the laboratory phase, mandibular incisal rests may interfere with the occlusion. Trim the opposing cast at the rest sites to allow occlusal adjustment of the rest of the bridge. When the rests are removed after bonding, proper occlusion should result. Later, the rest segment may serve as a good electrical connection for gold plating. These 4 views depict the standard design for anterior bridges as recommended by this presenter and utilized for over 4 decades. Avoiding gray discoloration of the incisal area will be described in another segment by gold plating the etched metal surface. Let us describe the tooth modification or preparation for a Maryland bridge. The proximal portion supporting a pontic segment should be trimmed to create a vertically broad proximal surface to enable a solid metal connection for a pontic segment. The pontic side of the tooth should be convex facial lingually, limiting prostheses to a vertical path of insertion and withdrawal. This is more important for mandibular bridges where occlusal forces attempt to displace the bridge lingually. Opposite proximal surface is trimmed only for a common path of insertion, and note the absence of vertical proximal grooves. The palatal lingual preparation in the palatal reduction should provide 1 millimeter occlusal clearance for the framework. Mandibular lingual reduction is indicated only for severely tilted teeth or in class 3 overlap situations. Tapered diamond burr serves as surveyor during the trimming. This concludes the restoration design and tooth modification for anterior retainers or bridges. Posterior retainers for intact teeth, where the intact teeth may include small lesions or restorations, which, if amalgam, may be bypassed. If cavity prep, may be restored with the cementing resin during insertion of prostheses, or if composite, the framework may overlay, the composite may be overlaid by the prosthesis. The term standard is included to distinguish this retainer design from an alternate design to be introduced later in the segment. The standard design is the original Maryland retainer and still generally applied. The proximal surface should provide adequate surface for a solid connection to the pontic segment. It should extend beyond the proximal facial line angle, aesthetics permitting. And it should extend from the occlusal marginal ridge close to the CEJ or gingiva for maximum bonding surface. And of course, it should be parallel to the path of insertion. The standard palatal or lingual segment should extend to the cusp tip. Maxillary cusp may require trimming for occlusal clearance. Should extend close to the CEJ or gingiva. Mandibular teeth may require greater trimming due to lingual tilting. And again, altered passive eruption should be corrected if necessary. In the standard Maryland posterior retainer, the occlusal rest, That small extension from the proximal onto the occlusal surface serves as a vertical stop and dissipates some forces. The standard Maryland posterior retainer, the summary is all three retainer segments are retentive. The maximum enamel surface is included in the outline. Existing restorations should generally be limited in size, or they could be circumvented, bypassed. Posterior retainer tooth modifications includes reduction for a path of insertion, an area adequate for a pontic connection, a wraparound extension onto the facial, aesthetics permitting, occlusal clearance of maxillary cusps, and no shoulder or chamfer finish lines. This concludes the retainer design and tooth modifications for the standard Maryland posterior retainer. Now, there are some trends that are contributing to the evolution of the alternate posterior retainer for intact teeth. These trends include the modifications of the occlusal rest to include small occlusal lesions and existing restorations, the expansion of the etched metal prosthesis to replace conventional inlays, the incorporation of etched metal onlay components to resolve lack of occlusion on tilted teeth, and the opportunity to include fused porcelain on etched metal components. So the alternate posterior retainers for intact tooth with the proximal segment is similar to the perforated retainer and the standard Maryland retainer in outline form. The palatal-lingual segment and the occlusal rest are eliminated, replaced with an occlusal segment. The occlusal segment is a shallow occlusal preparation which extends to the marginal ridge opposite the proximal segment and should extend facial-lingually approximately half the distance between the central groove and cusp tips. It should be 0.5 to 1 millimeter in depth and always within enamel. It should be 1 millimeter in thickness at the transition from occlusal to proximal segment. And near parallel walls are unnecessary for retention. These two restorations illustrate the conversion of the lingual segment of the standard posterior Maryland retainer to the occlusal segment of the alternate Maryland retainer for intact teeth. Alternate posterior retainers will be described in more detail as part of the management of compromised abutment teeth, as the occlusal segment becomes one of several categories of more involved inlay and onlay etched metal retainers. For the following review of actual treatment, the following criteria apply. Anterior bridges were routinely gold-plated except for the introductory 3 or 4 years. An opaque white resin introduced by Dr. Van Thompson was routinely used. Both electrochemically and chemically etched restorations are included in this presentation. Excuse the distorted color of teeth and soft tissues, as scanning of 30 to 40-year-old Kodachrome slides was not always successful. Porcelain pontics may appear lighter as adjacent natural teeth tend to discolor over decades, which also occurs with adjacent teeth to conventional porcelain or porcelain fused to metal crowns. Mandibular Maryland bridges are especially advantageous, avoiding potential pulpal involvement and fractures due to the narrow dimension of the incisors. Incisal graying is prevented with gold plating and opaquing bonding resins. Note the long-term continued success of 38 years. This 3-unit bridge was extended onto the other central incisor as a 4-unit bridge to balance the aesthetic changes that would occur with a lingual plate. Note the light pontic compared to the abutment teeth, with changes that may occur over years. Tooth number 7, the lateral incisor, is a crown over a pontic, later inserted to correct the shade, and was inserted 18 years later and 16 years prior to these photos. This 3-unit bridge was one of the earliest Maryland bridges, including both an anterior and posterior retainer. This bridge has been intact for over 44.5 years. As an early bridge, it was electrochemically etched. The canine retainer should extend more mesial and more incisal. This bridge is continuing to serve the patient for over 40 years. This is a 6-unit bridge supported by the 4 incisors and not involving the cuspids due to a large space after orthodontic treatment. This bridge was removed by the patient's current dentist to fabricate a longer bridge using the abutments of the Maryland bridge. This case is considered disrupted treatment. It's not a failure nor a continuing success. The bridge served the patient for 27.5 years. The lateral incisors were replaced with 2 3-unit bridges. Avoiding gray incisal due to the metal retainer with gold plating will be described in another segment. A 6-unit bridge could have been provided if ortho retention was desired. The patient and her multiple dentists were very supportive of the continuing success, almost 39 years at recent follow-up. This 3-unit bridge utilizes both an anterior retainer and the original posterior retainer, still intact at 37 years. These next 2 or 3 restorations illustrate a full mouth restoration with etched metal procedures. Left posterior bridge is still intact at 37.5 years. Second right bridge of prior patient also intact for 37.5 years. Same patient with an anterior posterior 8-unit bridge intact for 32 years. The bridge debonded and was replaced with a new etched metal bridge. Note that the 4-tooth segment was supported by etched metal retainers for over 30 years. So you do not think this is a rare exception with such a long pontic segment. The following examples may be more convincing. This 4-tooth span is even longer than on the mandibular arch. The bridge is in normal occlusion and not protected by creating an open bite. This bridge was intact for over 36 years when it failed due to a problem with one of the abutment teeth. The specific problem was not known. Note the open areas on the framework over the lingual cusps. This case is described in more detail in another segment. This patient illustrates an atypical application. Despite prior orthodontic treatment, the patient did not want the midline space closed, nor did he want it closed restoratively. The palatal connection of the 2 segments was included to prevent further widening of the space, that is to say, to serve as an orthodontic splint. Note the intact interval of 33 plus years. This bridge was intact for 38 plus years, but debonded on the lower left canine. For several other reasons, a combination bridge was provided with conventional crowns on the lower left side and etched metal retainers on the lower right side. My favorite bridge for testing longevity of Maryland bridges, almost 35 years. Long edentulous span with a cantilever effect due to the curvature of the pontic segment. This was not a bond failure, but fracture of the framework at the mesiolingual line angle of the upper left canine. This failure encouraged additional thickness of metal at abutment pontic transition. The patient was retreated with 2 implants and a 4-unit implant supported bridge. The implant option was not available at the insertion of the bridge. Consider that the retainers directly adjacent to the 4-tooth pontic segment would predominantly absorb and resist the occlusal forces and be the first to fail. The second retainer on each side can be considered to provide periodontal support instead of retentive support, or the second retainer may prevent tilting or drifting of the prosthesis forward. Double bite would require bodily movement of both splinted teeth, which would not likely occur. In summary, retainers next to 4-tooth Pontic spans best support reliability of etched metal retainers. A range of retainers shown to remain intact up to 30 to 45 years. Patients with clenching grinding habits were included. Restorations were designed in normal occlusion. There were very few open bites and no opposing dentures. It's not considered a protective prosthesis, advising patients for careful chewing. Double abutments are for periodontal support, not for retention, or for orthodontic retention to prevent drifting or tilting of long span bridges. Finally, you should compare the success of these prostheses with conventional fixed prosthodontics or even implant prosthodontics with 30 to 40 year follow-up. In treatment planning a fixed prosthesis, I select the best retainer for each abutment tooth. Combination bridges are common in my practice. Address any comments or questions to this email and consider including your telephone number for an optional response. Thank you very much for your attention.